أهلا بيكم. دي الحلقة الأولى من Oncology Watch، و Oncology Watch هيكون series of interviews and expert discussions focusing على hot topics in oncology. النهاردة بيشرفني إنه يكون معانا دكتور محسن مختار، Professor of Clinical Oncology in Cairo University and the President of CancerVive Patient Support Group. He's a well-known expert in breast cancer care and an ESMO, ASCO, and ISTRO and AMAC member. Dr. Mohsen, أهلا بحضرتك.
أهلا بيك لؤي. Thank you very much for having me. It's a pleasure to be with you today.
ومعانا دكتور حاتم عبد العظيم. Dr. Hatem, again, is a well-known expert in the field of breast cancer, specifically in the young and breast cancer during pregnancy. Dr. Hatem is an adjunct professor in the School of Medicine, Monterrey Institute of Oncology, and he is a senior oncology faculty in the College of the European School of Oncology, and he is the chief medical officer of the Emergence Therapeutic in France. Dr. Hatem, welcome.
Thank you very much, Luay. It's a real pleasure as well to be with you and Dr. Mohsen in this session.
Thank you.
احنا يعني النهارده هو الساعة 8:30، يعني الناس اغلبها يكونوا خلصوا شغل. احنا سنستنى دقيقة واحدة وهنبتدي على طول our discussion.
A hot topic يا حاتم, triple negative breast cancer today. New eras and new horizons in genetic testing for triple negative breast cancer, differentiating patients. Well, what's going on there?
Indeed, it's a very hot topic. I think, in my view, يمكن النهارده definitely we'll have a very rich discussion. I think what I can see the field going into how really to optimize certain treatments that we're going to discuss, the likes of Pembro, for example. I think, I hope we would be witnessing soon more appreciation to the different subtypes of triple negative breast cancer and how this could impact their treatment. Now, it's still برضو to an extent one size fits all from a biology perspective. Hopefully, this could be the next evolution in this field, اللي احنا to dissect a little bit the subtypes within triple negative breast cancer from a therapeutic perspective.
This dissection has been أكتر established في المetastatic setting طبعا, but hopefully in the neoadjuvant we're going to see the importance of PCR as we talk with Luay. I think that's an achievement, and I think how we're going to achieve more PCRs for our patients with early stage triple negative breast cancer. I think that's the whole thing on that.
واعتقد as well optimization لل post neoadjuvant phase اللي هو in those who do not achieve PCR. يمكن in HER2 positive الموضوع ابتدى يبقى اوضح الى حد ما في بعض الاسبكتس. يمكن في التريبل نيجاتيف طبعا برضو ممكن يبقى فيه شويه hints, بس اعتقد في مجال كبير للاوبتمايزيشن especially in our region برضو in which for various reasons برضو financial و others محتاجين certain select approach, وانا متاكد ان احنا will touch base على some of these points النهارده ان شاء الله.
تمام. I think ان احنا دلوقتي جاهزين ان احنا نبتدي. دكتور حاتم، يعني since decades كان standard of care في neoadjuvant chemotherapy or even adjuvant chemotherapy is 6 to 8 cycles of sequential anthracycline taxanes chemotherapy. However, this regimen, specifically anthracycline, associated with significant early toxicity زي الالوبيشيا واللي بيكون مش acceptable بالنسبة ل many patients. Indeed, also there is significant late toxicity which is scary for the physicians, like cardiomyopathy and second cancers. So the question which many patients are interested in, is there a chance that we can omit anthracyclines in patients with triple negative breast cancer under neoadjuvant or adjuvant even chemotherapy?
I think there is a chance for sure. Sorry, هو في echo صح؟
سامعين؟
I think there is a chance اللي احنا to omit chemotherapy in selected patients. طبعا I completely agree in الستاندرد اوبشن remains anthracycline taxanes، لكن في حالات معينه تحديدا elderly relatively some frail patients ما ننساش برضو ان المين one of the main competing causes of death في العيانين elderly هو وليكن cardiac events. ف this we need to take into account, and in selected patients this approach it's not unreasonable to think about it. في الحالة دي we could start بباكليتاكسل كاربوبلاتين أو تاكسينا كاربوبلاتين وليكن. أهم الأوبجيكتيف الألتيميت remains اللي احنا want to achieve very high levels of PCR as much as possible. الداتا اللي comparing anthracycline containing versus no anthracycline containing وليكن تاكسين كاربوبلاتين head to head ما هياش كتير. وإن كان عندنا study في study لسه published recently اسمها New Stop showed highly comparable PCR rates in the range of 54-55%. But this is as well re-emphasizing that maybe in selected patients we could think of this approach.
Okay, great. Again, let's remind ourselves the main goal is to achieve PCR in triple negative breast cancer, where many studies and a very large meta-analysis showed that patients who achieve a PCR would have around 92% 5-year event-free survival and 87% event-free survival at 10 years, which is a very good outcome in triple negative breast cancer patients. So in low burden disease, well, it might be acceptable. Dr. Mohsen, would you try that if the patient insisted, if she had, for example, a stage 3 disease or stage 2B disease, would you give it a chance to omit anthracycline?
We know in أي عيانة having lymph nodes is obviously of a high burden disease and is at a higher risk, and getting PCR, especially in our region in these high burden disease patients, which unfortunately we are seeing more of than in the Western countries, omitting anthracyclines or ننشيل anthracyclines, I think it's not something that I do, especially if I want to achieve a proper PCR. Anthracycline, remember, yes, it does have toxicity زي ما انت قلت, but let's also understand that paclitaxel and carboplatin, when you give it more than the 4 cycles, will also carry some toxicity. And لو احنا عندنا 4 cycles of anthracyclines and 4 cycles of taxanes, I think that's something that can be tolerated by most of our patients. لما نبص على things, new trials with immunotherapy, namely the Keynote 522 mandated the use of anthracyclines with paclitaxel and carboplatin. And on the other hand, كان في عندنا study بتاعت new trip اللي هي كان فيها الاتيزو with non-anthracycline that did not improve significantly the PCR rate. So it seems that there could be some sort of synergy with anthracyclines. لأن in the same atezo, but in the Impassion 031, the addition of atezolizumab lil anthracycline taxane-based chemotherapy improved the PCR, which I think still should be considered as the standard of care for a fit patient. And تماما مع حاتم, for those patients who are elderly, who have cardiac problems, maybe we can try and omit the anthracyclines. But in a proper fit patient, proper PCR probably is with that combination.
Okay, thanks, Dr. Mohsen. If you are going to plan for anthracycline for triple negative breast cancer patients, we have studies that have explored the dose-dense regimen, which is giving the same dose of anthracycline every 2 weeks instead of every 3 weeks. Who would you consider that regimen for? If in triple negative breast cancer.
Fit patient, I believe dose dense is preferable. كل أسبوعين with obviously with the SF support for that patient. We have the EBCGT data and obviously multiple studies. Recently, one coming out of Italy, the GYM2, showing that disease-free survival and probably overall survival benefit favoring the dose-dense regimen. أي عيانة تقدر تتحمله, I think fit patients should receive the dose-dense with consideration of the GCSF.
Okay. And do you consider patients who would want fertility preservation? Would that is this considered an issue to decide whether or not to give dose-dense regimen if she is willing to keep more ovens, for
honestly, this has been a debated area, لكن honestly not really. عشان وليكن في الجيم 2 study again, which is a study that was focused on I had a lot of patients with premenopausal patients. They did a subgroup analysis, or I mean a subsequent analysis, looking into whether or not premature ovarian insufficiency was higher, and here it was defined as a resumption of menses. هل يا ترى more women جالهم menses after end the chemotherapy, comparing dose dense with non-dose dense, and the results appear to be highly comparable. In my view يمكن in young patients, whether or not بالعكس أنا بشوف because young patients are younger on average more fitter, عندنا high prospects اللي احنا increase the chances of long-term outcome, يمكن they are classically more candidates لدose dense regimens, and I wouldn't be concerned إذا عيانة she wants to preserve her fertility. Obviously we'll discuss fertility aspects before starting therapy. لكن from a dose density perspective, I would not be more concerned using this regimen from a fertility perspective, provided I took the fertility preservation precautions ليها قبل ما نبتدي العلاج.
I just want to remind you that you can post your questions in the comments, and you will have the answers live while we go, or even after the session in the comments also. So now we are agreeing on anthracycline. I think we have a good agreement for the taxanes. So we have both options in the guidelines, paclitaxel and docetaxel. Dr. Hatem, which taxane would you prefer in a patient who is going to receive a neoadjuvant therapy for triple-negative breast cancer?
We have, there are several studies they compared the docetaxel with paclitaxel. The short answer بالنسبة لي, I strongly prefer paclitaxel. عشان in my view it's much better tolerated. لكن احنا عندنا data coming, بس let's go first للدata comparing both of them. عندنا a large adjuvant trial, ACOG 1199, compared two schedules of paclitaxel weekly or every 3 weeks, with the same for docetaxel, whether weekly or every 3 weeks, and it appeared that the weekly paclitaxel or 3 weekly docetaxel, they are highly comparable. يمكن in longer term outcomes طلع weekly paclitaxel has an edge as well, but from a tolerance perspective, weekly paclitaxel was way better tolerated. In my experience as well in the clinical setting, weekly paclitaxel as well is relatively easier to handle. محتاج very low doses as well, مش محتاج تدي steroids كتير. فأنا definitely I'm more in favor of weekly paclitaxel as well, obviously in triple negative breast cancer.
Dr. Mohsen, do you agree with that?
I agree, and because we're going to be adding, remember, a lot of these trials had paclitaxel or docetaxel as a single agent. Now, in triple-negative breast cancer, we are tending to add on carboplatin or platinum for these patients. So I think weekly paclitaxel with مع الcarboplatin هيديك toxicity or less hematological toxicity, which I think is more tolerable for the patients.
That's a very good point. Well, if you're going to escalate, maybe it's even easier to give paclitaxel. So again, since you opened the point of carboplatin, now with the relatively recent results of the brightness, many oncologists are more and more considering to add carboplatins in triple-negative breast cancer. So what do you think of that? Would you add it to all patients?
I would definitely be adding it to all patients. The brightness trial was very clear on whether the patients had BRCA mutation or non-BRCA mutation. You would get a benefit from the addition of carboplatin. في daily practice بتاعي أنا شخصيا I do add platinum أو carboplatin for my patients. We have some conflicting data from the CALGB trial, I think, but I do believe that the brightness trial was giving the platinum and the taxane the way that we are giving it today, and I think it clearly showed a superiority for event-free survival giving me a good reason to prescribe carboplatin for these patients.
So it looks like Dr. Mohsen is giving to most. Dr. Hatem, would you agree on giving to most? And to whom, if not?
I think to most it's not an unreasonable approach لو برضو لكن احنا برضو بالوقت بندرك ان one size fits all approach is not necessarily something and certainly هنا بنتكلم على الخطوط العريضة بس أنا agree لو to most carboplatin appears to be definitely adding something. From an escalation of therapy perspective أعتقد the higher the stage the more obvious the decision is. Triple negative breast cancer by definition, especially in our region, would present on average with a higher stage disease. فاحنا بنتكلم على stage 2, stage 3. This is to me an obvious thing. أعتقد برضو نقطة مهمة we need to take it into account. مريضة بتاخد AC أو anthracycline based regimen أول 3 to 4 cycles. Sluggish response to an extent. أعتقد هنا there is maybe even a more argument to add carboplatin to the taxane backbone.
Again, it looks like we're trying to give the most we have to patients with high risk disease or high burden triple negative breast cancer. That's very logic. So, speaking of that, pembrolizumab. So now immunotherapy have shown benefit in achieving PCR and even in the long-term outcome in triple negative breast cancer. So, would you add pembrolizumab to all patients or to most patients? Dr. Hatem.
أعتقد الداتا has been very clear والshort answer is yes. طبعا لمين we have maybe two main factors to comment on. Factor أولاني regarding الstage والفactor الثاني regarding PD-L1 expression. فإن this study احنا بنتكلم تحديدا على Keynote 522 study which added pembrolizumab to anthracycline taxane with carboplatin chemotherapy backbone. فاحنا بنتكلم from a PD-L1 perspective معظم العيانين في الستادي دي كانوا PD-L1 positive ولكن لما نيجي نشوف على السب جروب اناليسيز هنشوف ان irrespective PD-L1 expression ال PCR was fundamentally better with adding pembrolizumab, almost 15% difference even in both categories of patients, PD-L1 high or positive and negative. From a stage perspective طبعا lower stage patients whether they received pembro أو لا they had a higher chance of PCR, but again you still maintain almost a 15% difference, absolute difference when you add pembrolizumab in stage 2, and obviously this study allowed stage 2 and stage 3 patients and the benefit was seen in both. So I would rather for patients stage 2, stage 3 irrespective of PD-L1 expression I would certainly add neoadjuvant pembrolizumab.
Well, it's very valid point and even weird point if you think about it. For the triple negative breast cancer in the metastatic setting احنا عادة بنستخدمه قوي. And the benefit was almost exclusive in the PD-L1 positive patients. Yet in the early settings it looks like all patients achieved similar benefit. Dr. Mohsen, here regarding البوينت اللي قالها دكتور حاتم where we will add to all patients with stage 2 and stage 3 disease. First, do you agree with that?
لازم نحط into consideration financial toxicity في منطقتنا. It is a must. طيب, what would I do? Obviously, in my practice, sometimes I do test for the BRCA, and if I find that the patient is BRCA mutated, I might be giving her without the pembro in the neoadjuvant setting, and if she doesn't achieve a PCR, then I can shift to a PARP inhibitor for that patient. That's one way to look at it. But في المجمل, no, I do believe in the neoadjuvant setting, yes. Do I need to continue further than the neoadjuvant in the adjuvant setting? طب والعيانين اللي ما حصلهمش PCR, do I need to add on capecitabine? Can I look at PARP inhibitor, olaparib? There are trials ongoing with PARP inhibitor in the BRCA mutated plus pembro if the patient doesn't achieve a PCR. It's not recommended till today, definitely. But would I not give it? لا, يعني if the patient is financially sound, not BRCA mutated, or I haven't tested for a BRCA mutation, I think I would be giving it in the neoadjuvant setting for all patients. If the patient achieves a PCR, till today I am giving it post PCR, but if we see the overall survival data that comes out later on is this disease-free survival curves, are they still going to be separating ولا لا? I think is something that we are all waiting eagerly for in patients who achieve a PCR.
So you're thinking of de-escalation in PCR patients, and it looks fine with the
نفسي اعمل دي اسكيليشن في البي سي ار patients بس مش قادر اعملها لغايه النهارده.
Okay. طيب one last point for patients who did not achieve PCR. يعني في البداية مع الداتا بتاعت الكرييت اكس it was very promising وكانت يمكن مريحة لينا لأنه الكيبسايتامين is an available drug and we have a lot of experience using it and relatively cheap. So now who would you give adjuvant capecitabine, دكتور حاتم؟
adjuvant capecitabine في العيانين اللي they did not achieve PCR is still valid بالنسبة لي جدا جدا. أنا I joined دكتور محسن في موضوع ال validity of continuing giving Pembro post neoadjuvant in patients not achieving PCR, and I think and I hope the data that will be coming out will show us that this is not necessarily adding much. I do not think it will be adding much, by the way, but this is just my speculation. بس أنا I understand صعب نعمل ده out of a context of اللي ما فيش data. فأعتقد أنا من وجهة نظري هنا زيلودا أو capecitabine in the adjuvant setting in these patients is a very valid option. If as well we take into account the financial toxicity. In BRCA mutant patients بالنسبة لي الموضوع واضح. olaparib definitely is the best and the first option. لكن in BRCA wild type TNBC with a residual disease post-operative, and certainly capecitabine is a very valid option بالنسبة لي.
Hatem, are we going to see PALB2 coming in as part of as BRCA patients? Do you think that's something that we're going to be treating نفس الطريقة as a BRCA mutated PALB2 in the future years to come?
والله it's a difficult question. في some elements بتsuggest in maybe certain behaviors is close to germline mutated BRCA mutant. In وليكن in the Olympia trials it was strictly for the BRCA mutant patients. طبعا it is hard to imagine إن هيبقى في dedicated study encapsulating only these mutations عشان they are not necessarily a lot. It's a tough question. I have to say it's not necessarily أعتقد if we have proof of concept studies showing fundamental benefit in these patients, I think this something could be considered down the line.
والكيبسايتابين يا لؤي يعني adding on to what Hatem said, بس الكيبسايتابين مشكلتنا أنا مشكلتي مع الكيبسايتابين we have some conflicting data. We also have an Italian trial showing that there was no benefit بالدوزز اللي احنا بنديها في الكيبسايتابين. Remember that the Asian trial they were giving a higher dose,
Very high dose.
25% higher dose, which is something that you have to take into consideration مع عياننا. If we have something dedicated in our region to capecitabine, but again, when my patients haven't been able to afford Pembro and they don't achieve a PCR, till today I give capecitabine the أكيد.
Great. So, thank you very much. I've enjoyed the discussion. Dr. Hatem Abdelazim, Dr. Mohsen Mokhtar, it was really a pleasure. I hope you enjoyed as well, like me.
We enjoyed very much. Luay, thank you, Hatem. Nice seeing you virtually. Well, Luay, thank you very much. And to the audience, we hope you enjoyed this and it was beneficial.
Thank you very much. It was a real pleasure. ميرسي جدا.
احنا الأسئلة لسه مكملة، يعني ممكن تبعتوا الأسئلة واحنا هنرد علشان بس ما نعطلكوش، لكن الأسئلة ممكن تتجاوب all the way يعني. شكرا.